Good evening, friends. Welcome to this Tuesday evening master sessions from Yashoda Group of Hospitals and Department of Critical Care Medicine. So we have been doing this for more than 5 years now, and these sessions happens to be the interest of current audience. And today we have again another interesting story. The vasoplegic shock, purely when you have vessels which are paralytic and you are vasoplegic, the role of VA-ECMO has always been debated in those kind of categories, and more so for a conventional concept. These patients come under a relative contraindications for a VA-ECMO. Over a time, we understood the complexity. Sometimes it is not a pure vasoplegia alone. There will be a lot of interplay between vasoplegia, myocardial suppression, inflammatory phenomena, maybe hypoxia, acidosis, lactatemia, all playing a role in killing these patients. If you set some of them, can we have a role to play that? So to bring those discussions, Dr. Brijes made an attempt and probably looking at those cases, and one of its presentation in SWAC also made me to thought about that case may makes a sense to evaluate. And in recent times, in the last week, Dr. Kaladar, in one of his patients, required a severe vasoplegic state with intra-abdominal sepsis, needing some amount of support. So at that point of time, the discussions came, what is the cardiogenic part? What is the vasoplegic part? Do I need really to put these patients on a VA-ECMO? And we will listen his story today. But before that, I have a privilege and honor to invite Dr. Sunil Kumar Povani sir, a mentor, a senior guide, and a teacher for many of us in India back here. He carries a rich experience of 20 years in United Kingdom and here in UAE. And he's the chief in the Department of Pediatric Critical Care, Mediclinic City Hospital, Dubai, UAE. It's an honor for us to have you, Dr. Sunil Povani sir. Welcome.
Thanks, Venkat, for the invitation. It's an honor.
Yeah. So that second person is none other than Dr. Brijes B. Patel. He happens to be the clinical associate professor in cardiothoracic critical care, anesthesia, pain medicine in the Department of Surgery and Cancer, Faculty of Medicine, Imperial College London and UK. You can see the background of his is the Imperial University. Welcome, Dr. Brijes Patel. It is really a honor for us to have you on board who has some real first-hand experience on that so that we can actually create awareness on that. Welcome, Dr. Brijes.
Thank you, Dr. Venkat, and thank you all for the invite. Pleasure to be here.
And back to Dr. Kaladar, the man behind the reason why we are all here. And post 2 weeks of Dr. Brijes, a case came to his ICU and he tried to explore the option of a VA-ECMO in a vasoplegic patient, and we'll see his story. Over to you, Dr. Kaladar. After this, Dr. Kaladar's case presentation, we'll come back to audience and some interactive sessions with both the experts. Over to you, Dr. Kaladar.
Thank you, sir. Thank you very much, sir, Venkataman Kola, sir. And thank you, Dr. Sunil Kumar Povani, sir, and Dr. Brijes V. Patel for coming onto our platform. I will start my presentation. So the presentation basically starts with the case we have dealt with in our ICU. And then we'll review part of the literature. Are you able to see my screen?
Yes, Kaladar.
Yes, yes. Move to the next slide.
Yeah, I think.
Yeah, please.
So moving, sir. Yeah, thank you. So this patient happened to be a 55-year-old female with past history of hypothyroidism, psoriasis. She takes like steroids on and off, and along with that topical steroids also, some Ayurvedic medicine, and the background of history of hysterectomy was done. But later she had developed abdominal incisional hernia for which the mesh repair was done 4 years back. Other than that, she was fine, moving around and everything, the baseline activity is fine. So what happened is she had a history of the pain abdomen, which was diffuse in nature. So for about almost 2 days. Then she happened to have vomitings 2 episodes the day she presented in the morning. So she came to our ER in the evening around 4 p.m. So when she came to our ER, she was conscious. The sensorium was fine, but she was having severe tachycardia of around 120 to 130 per minute. The BP was around 80 systolic. Definitely the blood pressure, she is in shock. With saturations of 90% on room air, a bit of hypoxia was there. So as any generally what we do with any shock initially, especially suspecting on the background of intra-abdominal sepsis, we started an IV fluid resuscitation with crystallites, balanced crystallite solutions. Around 2 liters were given. So with that, the BP came up to around 90 by 50, but even after that, it is still on the lesser side. So because of which we had to start our noradrenaline support, which is around 0.12 microgram, 0.1 microgram per kg per minute. So when we clinically looked at the parabdominal examination, it showed definitely there was incisional hernia defect can be palpable, and with that there is diffuse tenderness along with guarding and visibility. The typical of the peritonitis that we generally look at any patient. The moment you just put the hand on the abdomen, she is screaming in pain. So of course, at that point of time, she was continuous to be tachypneic, tachycardic, and shock was persisting. So these are all there. She was becoming a bit irritable. And when we look at the ABG, it is showing severe metabolic and with less respiratory compensation, not up to the point because of probably a bit rapid shallow breathing and hypoventilating also, not able to compensate to that. Because of which we thought, I think, and there is a lactic acidosis, we thought it's better to go for anyway, as we look at ABC, airway breathing, and we intubated her immediately at that point of time, taking proper precautions. So because the abdomen is clear-cut, they happen to be the source of infection, after a bit stabilization and noradrenaline support and ventilator, we took her to CT abdomen. If you look at the CT abdomen here, in this picture, the anterior abdominal wall defect is there. That is incisional hernia, from where the large bowel is coming into this hernia, and there is gas collection extraluminally. There are other sections where the extraluminal gas was very much evident, which indicates definitely there was a perforation. And when we discussed with our radiologist, they said the possibility that the perforation may be in the transverse colon. So with this, we involved the surgeon. The surgeon came, the gastrosurgeon came immediately. And then on the noradrenaline support, initially only single vasopressors. The baseline 2D at that point of time was showing around global hypokinesia with EF of around 45%. So with this, we took her, like the surgeon took her into the OT to control the source. An emergency laparotomy was done, which found to have the fecal peritonitis, lot of feces, as they were telling. So they drained all that feces, and along with that, there is a defect in the transverse colon. It was a bit strangulated hernia, along with the perforation happened in the transverse colon. So they did a resection of the segment and did the end-to-end anastomosis, and they brought out the ileostomy, and then mesh was explanted, the previous mesh which was there. So with this, during intra-op itself, the patient was worsening shock. They also resuscitated almost near to 2.5 liters during intra-op also, but even after that, the shock was worsening. We went on to start on vasopressin, adrenaline, and she came to our ICU. So she came to our ICU probably around in the early middle of the early morning. So what happened continues to be in severe shock. We did a 2D echo at that point of time. So it was showing the severe LV dysfunction. So the initial, whatever the global hypokinesia with moderate LV dysfunction worsened further to progress to severe LV dysfunction. That is when in the morning we discussed with the attendants, and when we told them that it looks to be very bad and triple vasopressor support, I think we may not be able to salvage her. Only the option possibly because there is a cardiac dysfunction along with severe septic shock. So we explained to them clearly that the ECMO can be tried in this patient. So, and another thing, when we looked at the vasopressor inotropic score, So it came around 176 with a norepinephrine of 1.5, vasopressin of 0.04 units per kg, and epinephrine of 0.2. So with this, before the introduction of the ECMO support, the ABG was clearly showing lactic acidosis, lactate still persisting around 8, and the metabolic acidosis is worsening with higher and gap metabolic acidosis. So the options, as I was discussing, we had a detailed discussion, and then we went on starting an ECMO. We started an ECMO around 2 p.m. So the duration, she came to our hospital at 4 p.m. and 2 p.m. we started. Next day 2 p.m. we started around. We could take around to VA-ECMO support. So near amount to 22 hours, but after worsening shock, probably within 12 hours of time, we could able to put our own VA-ECMO support. So the route what we have taken is femoral. The because of probably very high vasopressor support, the arteries were very much tenosed. We could not able to actually cannulate initially. Anyway, we did cannulate with a bit less French, 25 French for venous and 17 French, around 55 kg lady, 17 French of the return cannula. Along with that, initially we put some French reperfusion cannula and then this one. But the reperfusion cannula, the backflow was not coming. So because of which we had to involve our vascular surgeon, where we cut open and then again put a reperfusion cannula along with the veno-arterial cannulas. So we were achieving around 3.5 to 4 liters initially, slowly going up on the flow. And then hemodynamics improved over a period of 6 hours and could able to drastically come down vasopressor support. And she was requiring moderate dose of noradrenaline at that point of time. And the subsequent ABG still continues to be bit after 1-2 hours, still continues to be in metabolic acidosis, but lactates were coming down at this point of time. So this is our team where we initiated the patient on ECMO with this reperfusion cannula and veno-arterial right femoral vein and right femoral artery. And this is the patient on ECMO and post-ECMO X-ray and pre-oxygenated, post-oxygenated pressure. That's what we were monitoring, and we maintained the ACT between 200 to 220 throughout our ECMO period. So yeah, she was improving very well. Noradrenaline almost came to, almost every day we were doing came down to very less support. Along with that, every day we were doing 2D echo to look at any LV distension is happening. To our surprise, actually within 24 hours, LV function was very much improved, and the oxygenation was also good. Prior to ECMO itself, the PF ratios were around 200. Lung was not much the issue. It's rather more of the heart. And urine output also initially before ECMO, it was dropping down, and after ECMO, with good perfusion, the urine output was being maintained. So the problem here is after 2 days, the patient was having right lower limb ischemia. Definitely the foot was cold to touch, despite a very good reperfusion cannula even cut down and after that. So we were, the arteries were definitely very small. Probably the stenosed arteries caused the problem, we don't know. So we thought it's, and there was another issue with her sensorium. The right side of her upper limb and lower limb, she was not moving much. She was able to follow our pupils and everything fine, but we thought even the possibility that hemorrhagic stroke might have happened, because of which, and CPK, we looked at CPK was going up and creatinine was going up. So we were doing urinary alkalinization and all those things for rhabdomyolysis. Along with that, because of which we had to decannulate on day 3 because the 2D was showing good LV function. So then after decannulation, we took her to CT scan. CT scan was surprisingly showing ischemic stroke. If you look at the hypodensities in CT scan, this is hyperparietal occipital area along with frontoparietal in different, the multi-embolic stroke kind of situation. We thought it might be because when the hemodynamics were very poor, probably she might have developed this ischemic stroke. So because of which, and she developed definitely a bit of critical illness neuromyopathy later. So because of which we thought it's better to go for a tracheostomy and a weaner. So she's getting weaned and now getting rehabilitated in our ICU. So with this background, I will go through a bit of literature review. So most of the times, what is the context that we think of VA-ECMO in the background of septic shock? So some of the literature dated back, like showing like even some pneumococcal diseases or viruses have a preponderance towards causing the cardiac micro lesion formations, subsequently leading to cardiac scarring. They have a cardiotropic action where they may damage the cardiomyocytes, because of which the patient may land up in the septic cardiomyopathy. Most of the times it is being reversible with this big 30, 40 years back paper, where if you look at in this, they called it as a circulating myocardial depressant substance, what we call nowadays as cytokine storm with endotoxin, TNF alpha, interleukins. They cause definitely the contraction of the myocardium to go down, because of which the patients, especially those patients who develop the septic shock, are at risk of this problem. So an interesting article which is being published in the intensive care medicine, sorry for that. So understanding cardiac failure in sepsis, what are the different profiles that generally these patients can have? So it can be because of the depressed intrinsic myocardial performance, can be because of different profiles, like predominantly most of the times it can be LV systolic dysfunction followed by LV diastolic dysfunction, and there can be, especially if it is the sepsis associated with pneumonia, the RV dysfunction is also a possible phenomenon in this patient. So all these profiles are possible in patients with septic shock. So other than that, it's not only the organisms, it is the therapy. That's what we put these patients on a lot of catecholamine, stiff vasopressor support. Catecholamines itself lead to kind of Takotsubo cardiomyopathy, the catecholamine-induced cardiomyopathy, where they can cause the cardiomyopathy in addition to septic cardiomyopathy, which can worsen the scenario as such. So the Gary et al., they observed different hemodynamic patterns based on, one is volume, one other is the contractility, the preload, contractility, and the afterload. It's what generally we look at any patient developing shock. So the profile, if you look at the profile where it is being depicted in the red, they have an associated significant LV, decreased LV ejection fraction. These constitute around 17% of the patients among septic shock patients, and they are likely to go to have a very bad mortality. So this is what they looked at. So I think so. The another study where they looked at sepsis-induced cardiogenic shock, the outcome of patients with septic shock and high-dose vasopressor therapy. In this also, they looked at very high-dose vasopressor support in 106 patients. The 28-day mortality, they have LVEF of less than 35%, near to 81%. So even though you try everything in these patients, the patients are likely going to die 80% of the times. So with this background, I will take you through what is the literature. The literature mostly pointing towards, as we know, in patients, pediatric patients. So especially the McLaren from Australia did the series of studies where they could demonstrate a very good outcome in patients with pediatric patients with septic shock. They tried central ECMO in these patients. And if you look at in their paper, almost 18 patients among I think around 25 patients, they survived. Near to 78% of them could survive, and 74% could have a hospital discharge, which shows the ECMO definitely a very good turnaround mechanical circulatory support device in this subset of patients. Most of the data points towards the patients of pediatric age group where they have a good outcome as compared to the adults where the possibility that the outcomes are not good. Even if you look at the adult the neonatal and pediatric American College of Critical Care Medicine septic shock resuscitation, along with septic surviving sepsis guidelines of pediatric and neonatal, they mention ECMO in refractory shock patients as the important rescue therapy based upon these series of studies. So they could include in this. So with this background, why the VA-ECMO functions helps in pediatric patients as compared to adults? What is the profile that makes a differentiation between those two? If you look at the age-specific hemodynamic patterns here, so the neonatal hemodynamic pattern is most of the times it is right heart failure, persistent pulmonary hypertension. Pediatric age group, it is predominantly left ventricular failure. But when the human progresses to adolescent and adult, the septic shock takes predominantly the form of distributive shock, where the capillaries are involved and the oxygen extraction is compromised. That is the reason the ECMO upfront in these pure distributive shock may not help. So that is how. So are there any studies, adult studies? Yeah, the studies initially, most of them came from Asia, especially Taiwan and Korea. If you look Huang et al., they published in Journal of Thoracic and Cardiovascular Surgery, where they looked at the VA-ECMO support in adult patients with refractory septic shock. The survival was only 15%. So what is the one limitation in this study that we are as we are speaking? So here, if you look at left ventricular ejection fraction, it is normal in them. It is more than 50% in all the patients where they instituted VA-ECMO, and they could achieve the flow of only 2.6 liters per minute median flow, which is very less flow, and there is no associated cardiac dysfunction. Probably that led to the less survival in these patients. So, and are there any associations of the different types of infections and the patients who go on to extracorporeal membrane oxygenation, the predictability of mortality in these patients? Definitely, I think when they looked at the hazard ratio between the pneumonia and bloodstream infection, definitely the patients who are in the subset with pneumonia, myocarditis, and gram-positive cocci fared better. If we institute the VA-ECMO in the subset of patients, probably they do better than the primary bloodstream infection patients. And non-fermentative, especially non-lactose fermenter GNB infection, and along with GNB, also has shown to be a very poor outcome, the hazard ratio, if you look at 2.4. So that is how the Aristine Chang, they looked at in different types of infection. This is one of the probably very sound and very big study. A retrospective study was done by Nicolas Pechard and Paris and French study, the veno-arterial ECMO to rescue sepsis-induced cardiogenic shock. So this is a multi-center study across Paris and other centers where they put the ECMO. They looked at between 2008 to 2018. Among them, 82 patients were included in this, where cardiac index is less than 3 liters per minute and LVEF less than 35%. So in this, if you look at the survival at 90 days is almost 60%. So here the mortality benefit clearly being shown. If you look at the ECMO versus non-ECMO, the patients who gone onto ECMO, definitely most of them had a source of infection as the lung, and the pre-inclusion cardiac index was very low. LVEF mean it is 17% as compared to 28% non-ECMO, and pH was definitely severe metabolic acidosis and lactates was low with very high inotropic score, predominantly telling that these patients are more sickest and definitely had significant cardiac involvement. So in these patients, of course, they compared between survivors to non-survivors, definitely because they are going to go on prolonged VA-ECMO support, have a bit of major bleeding and amputation. Those risks, and RRT was more duration, mechanical ventilation was more duration. These were all there. And what is the profile of these patients, why the difference in outcome was there? It is a very specific hemodynamic profile as we were discussing. It is low LVEF, low cardiac index, and there is a high vascular resistance. These kind of patients were been included in these patients. So looking at different studies as of now, the most commonly cited studies where you look at, I think Brechot is the one, as we were discussing, the retrospective study and their own study, which is showing the survival up to 60 to 70%. All other studies did not show much benefit other than the McLaren study of pediatric group. So, and then another study they did, the veno-arterial extracorporeal membrane oxygenation, MCS, as a MCS support, a systematic review, where the definitely the Nicholas who were there in retrospective studies been also included, and Singapore-based Ramanathan sir was also included, in Lane Combs. In this, they looked at almost 12 studies with among 458, all 12 studies, there were around 458 patients, and they grouped these patients as having EF of less than 20% and 20 to 35% and more than 35%. So there is a clear-cut delineation of the patients who had the EF less than 20% had a very good survival in these patients, near about 62%, as compared to patients with more than 35%, around 32% only the survival in these patients. So this is how they did. So with this background, yeah, definitely when we look at the ECMO support, these patients who have predominantly cardiac dysfunction, they require VA-ECMO. But VA-ECMO patients most of the times tend to have the mortality on the higher side. Sometimes these VA-ECMO patients may have to be converted to VV, and predominantly if the patients have lung as the source with ARDS, with may not be more very high dose vasopressors, they do better with VV rather than VA-ECMO. And definitely echocardiogram, that may make a difference. That's what you have to look at, especially the EF. So with the come to the basics of what is actually in layman terms, we speak in ECMO, the pump is nothing but the artificial heart, and the oxygenator is the artificial lung. So definitely the pump supports the heart and the oxygenator supports the lung, but ECMO can support both of them, but it may not be able to support the capillaries as such. That is what the distributive shock that is there, it cannot support. So come to almost the conclusions of my slides. The ECMO is associated with a drastic reversal, especially if it is a mixed shock, along with septic cardiomyopathy, predominantly EF less than maybe 30%. The survival may be better if you early institute the ECMO. Complete myocardial recovery is possible because most of the studies say reversible myocardial dysfunction will be there. Good quality of life will be there after post-ECMO in these patients. They looked at in Nicholas study also. And it is a pure refractory vasoplegia. It may not be helpful. And early the ECMO institution is very important. This is the chart. This is the table where I have taken it from our red book, also red book, ECMO cannulation strategies. If you look at the neonate, young child, older adult, and any age, initially, definitely, as I was telling, neonates, they have predominantly right heart failure. So they have a low cardiac output with high SVR. As it goes towards adolescence and adult, the possibility it leads to predominantly distributive. Sometimes initially it may be distributive. Later the heart involves, it becomes a mixed shock. So during distributive, ECMO may be unnecessary or inappropriate. And if it is probably concomitant refractory cardiac and respiratory failure, generally sometimes putting patients on central VA or, yeah, definitely in some studies, peripheral VA helps. And if it is associated with hypoxia, VAV ECMO helps. So how do we decide when in the context of a patient coming with septic shock, is there a decision-making algorithm where I can rely upon? Probably this is one algorithm where when the patient is in septic shock, you look at ventricular dysfunction. The ventricular dysfunction is bilateral or unilateral, you have to determine. If it is isolated right ventricular, mild right ventricular dysfunction, of course, you continue with optimizing hemodynamics and ventilatory parameters and other adjunctive therapies. When it is progressing towards severe or moderate right ventricular dysfunction, along with probably vasopressor support, it is better to go for veno-venous ECMO. And when it is left or bilateral ventricular dysfunction, probably the severe LVEF, around 20% they mentioned, probably around 30% early institution go for a VA. So this is how we have to be open to all sorts of, the minds are like parachutes. They only function when they open. We have to be open to this rescue strategy, probably looking at the heart, and once there is a dysfunction, think about the VA-ECMO in this subset of patients. So with this, I conclude my presentation. Over to you, Venkat sir.
Yeah, thank you, Kaladhar, in bringing that case, and I think that will open the discussion. So coming back to, we have a very enthusiastic audience putting questions in and around. So to start with, Dr. Brizes, it's a physiological mismatch. VA-ECMO, as Kaladhar said, it supports your lung and heart. Why are you talking about a vasoplegic process? So agree, disagree, and you wanted to individualize.
Yeah, no, absolutely agree. Thank you, Dr. Kalada, for that really nice presentation and the case. I think the important thing to simplistically realize is that there's the extremes of the spectrum. You'll have full cardiogenic, isolated heart failure, acute cardiogenic shock, which VA-ECMO can support. Whereas then you'll have full septic shock with an inflammatory burden, as was in this case, where cardiac compromise occurs. So I think we know that, simplistically, VA-ECMO is a pump, and whilst it gives you oxygenated blood, it, in many patients, particularly in sepsis and vasoplegia, if you have a hyperdynamic state, it's very difficult to replace that level of hyperdynamic cardiac output. So it's that balance of deciding what native cardiac output there is versus what artificial cardiac output you can support. Realistically, in adults, 5.5 liters maximum, right? And I think the key bit is trying to make sure that you don't have competing flows within that. So I think that's the key kind of component from my experience of doing this. So critical care, we look after shock. It's undifferentiated shock when the first patient presents to you, and then you get an idea of what components of shock are key to this. And I think this is where we have to have continuous input and getting data from the patient and making sure that we monitor them and look at trajectories of vasoplegia, cardiogenic compromise, and distributive obstructive shock from the ventilator as well. So one of the few questions I kind of had from the case, and it's a common case, not an uncommon case that we would see, it's so, for instance, you've had an abdomen there that's been compromised, and the surgeons have done a great job, but then you're going to have elements of, bacterial translocation, inflammation. Was the abdomen closed first off? And so do you think there was any component of intra-abdominal pressure that then's leading to ventilatory compromise, which then leads to higher pressures, and then you get a vicious cycle of high cardiopulmonary interactions, and then further noradrenaline and inotrope pressure support.
So, what I believe and understand is the abdomen was decompressed well after the evacuation.
There was not much of any intra-abdominal pressure.
Yeah, and there is a ileostomy done. So, as you mentioned, the predominant component was when you handle the tissue and you do anastomosis, you have a bacterial translocation, and it's very not uncommon to see that the patients will get a loads of bacteria translocated to the bloodstream, and you go down for a day or a half a day.
Exactly.
That's the more component. Then abdomen was quite okay, and till now, the patient from abdominal point of view was quite fine.
So this is, an example of a case we had where we had to leave a laparostomy, leave the abdomen open. The hemodynamics improved, but the lungs were down, and so we went to VV and supported that. So it's that mixture. So I think importantly, it's not a binary decision tree. It's a mixed kind of shock decision tree that we have to make. So I'll hand over to others.
So, Pawan sir, there is a
Just one clarification. As we had concerns regarding the perfusion of the limb, what happened ultimately after day 3? Was the limb saved?
Yeah. Yes, sir. We could able to salvage the limb, sir. Because we decannulated early, and there was another issue of definitely the stroke. So that is the reason we thought, I think, ECMO at this point of time may be doing more harm than the benefit. So that
so
is the reason we went ahead and
yeah.
decannulated, and there was a bit clot in the reperfusion cannula that was there. So we decannulated her in OT because we did a surgical cut down for that reperfusion cannula, and it was sucked out the numbers, and after that it improved very well. So the fasciotomy was also done. We thought probably there is a compartment, but the limb muscles were good, healthy. So later it got better.
From the literature, some of the people have reported perfusion to the limb issues here, and they preferred perfusing from the ankle from the posterior tibial as well in some of these cases. That is very interesting.
Okay. Sunil sir, we'll come back to that. The basics question first, like if I have a patient on a VA-ECMO for a cardiac reason or a mixed distributive or a kind of probably defined shock where there is an overlap of couple, and the patient develops a vasoplasia, quite possible. You initiated for more of a predominantly myocardial issues with the vasoplasia, but the vasoplasia worsens further. So how do you manage those cases where we have undifferentiated shock you initiated, but vasoplasia is worsening? So most of the times we do deal with these situations. So how do you play with the vasopressors and what do you do in those scenarios?
Yeah, very good question. And also a practical question, Venkat. Like these scenarios, there will be a triggering factor more often than not. So, till these triggering factors they come under control, we can play with various essential inotropes which we know of, such as epinephrine, norepinephrine, vasopressin, dopamine, dobutamine, milrinone as a vasodilator to some extent. In our practice, what we have done is when we have used a significant amount of pressors, then it is ideal to have a tinge of an agent such as milrinone as well to balance the effect. It is not for further worsening the um, vasodilation, it is only for the balancing purpose. Again, with the inotropes, we don't go to the top maximum as it is mentioned over there. To a reasonable extent we can increase it and then mix and match with the inotropic support. These are the fundamental basic inotropes that we tend to use. Besides that, make sure the acid base balance is also within limits. The other Once this has been achieved and still we have problems in maintaining the blood pressure, people have tried using other agents such as methylene blue or hydroxycobalamin, etc., in refractory cases, as they target the nitric oxide mediated vasodilation through their use in is generally reserved for failure of conventional therapy.
We used
The
methylene blue in this patient, sir. I didn't mention
methylene
it.
blue, yes.
Yeah.
And angiotensin 2 is another agent which has been tried as well in these cases. Obviously, volume optimization, fluid resuscitation is important on one step, and again balancing with the inotropic requirement as needed in these cases as well is the right approach to do before proceeding for ECMO support in these cases. And the serial trend of lactate, you're shown as a lactate of 7.1 in this case.
Drop
The
it down.
serial trend of lactate and venous saturations, they are also surrogates for us to see how the patient is improving or deteriorating.
So some of those curious questions from the attendees, Dr. Brizes, what are the cutoffs of cardiac index you take to decide your VA-ECMO in a septic shock? I think Kaladhar has presented some data from the
Mm.
recent systemic review. What is the cutoff you take?
Yeah, so that's the key, I think, statement I can make here is it's about oxygen delivery, right? And I think the key bit is a cardiac index that we may want in normal health is very different to a cardiac index required in a hypermetabolic septic patient. So I think it's not an absolute number, but I think it is a trend towards, is this cardiac index enough for the demands of this patient? And is there end organ dysfunction as a result of that? So I think the key component is looking at lactate, looking at urine output, looking at organ perfusion, mottling, clinical signs to be able to do this, because a cardiac index of 1.2 is usually quite too low for someone, but a cardiac index of 1.8 may be just enough for someone. So I think that's the balance that I would say here. I think going back to what Dr. Pavani mentioned in terms of the way we manage hemodynamics is also really important. So I would always advocate for having an idea of what ventricular arterial coupling looks like. What you don't want to do, particularly in established patients on ECMO or non-ECMO, is aim for a blood pressure. You increase inotropy and vasopressors in particular to supraphysiological levels to obtain a blood pressure, but your ventricle cannot pump as a result of that. So I think your cardiac index will be very much dependent in these cases of not only your cardiac function, but the manner in which you institute vasopressor and inotropic therapy. And I think it goes back to having a mixture of inotropes. So for me, I don't mind having a little bit of adrenaline, a little bit of noradrenaline, milrinone, and using and vasopressin, using all of the inotropes in, rather than have one really high vasopressor versus, very low inotropy. So having a mixture and using the basic pharmacology to the best of your ability. So I think that determines it. The study that I think Dr. Kaladas showed about ejection fraction, about having a low ejection fraction and survival benefit, that cutoff was around 20%. So an ejection fraction of 20%
Number-wise.
less than
The lower it is, probably the better the survival benefit, because
the better survival.
Yeah. So the other
Exactly.
question is, you raised a point related to, you said the oxygen delivery mismatch at this hypermetabolic inflammatory conditions. So how do you assess that? How do you come to the conclusion my patient is not getting adequate delivery? A normal thing, but in a complex case like this with multifactorial overlaps, how do you actually define? There is a question related to, does a macro and microvascular mismatch, you said LV and you are constricting your vessels mismatch. You may constrict your
Yeah.
vessels more, and your heart is not able to cope up to pump against those high vascular resistance if you're trying to squeeze it too much. So what is the practical real world tool or the value you use to see that mismatch and add these points?
Yeah. No, it's a really good question, and I think it's very much about how we, as intensivists, we only have the big numbers, right? We have radial.
Macrodynamic.
Exactly. We only have that. So actually the metabolic component is making sure, for instance, having a PA cath in and getting central venous oxygenation, particularly, off of ECMO. If that is very low and your delivery is poor, then we know that extraction is more and the body needs more. If your liver starts going off, so if you've got end organ dysfunction, we know that at a microcirculatory level, that's a problem that you've got. We can't do much about microcirculation. That's the bottom line. I think it's having the wisdom that we can't influence that. That's the disease process. But we can only manage what we can influence, and that are the big numbers. So if you have I think one of the biggest things I would suggest is, if you have a radial arch line in someone who is so shocked, you need to put a central arterial line in, because you're going to have a big central peripheral mismatch. Having central monitoring of PA pressures, having a PICO in, so you're continuing to look at that and trying to optimize oxygen delivery and cardiac index as best you can is the best component that I can suggest here. I think just the final point is, I think there's also more and more appreciation of the effect of high dose vasopressors, not only on the systemic circulation, but on the pulmonary circulation as well. So how vasopressin and noradrenaline, particularly high doses of noradrenaline, cause increases in pulmonary vascular resistance and then worsen your right heart and your disconnect between the right heart and your connection between the right heart and the left heart, I think is underestimated as well. So I think all of those components need to come into play.
Okay, that's a great point. And Dr. Sunil, sir, there are a lot of questions related to you're trying to support the heart or some amount of oxygenation and lactate. But the real problem is a sepsis, infection, cytokine storm, inflammatory mediators, and all. So there is a lot of enthusiasm and interest related to do we have a way where, like a source control, Dr. Kala has done a source control, but during the source control also, we do see some amount of translocation of bacteria. There is a surge of inflammatory kind of a markers going up and the patients going down. So filters in them, including all those which actually heme adsorption filters or your polymyxin based filters or your auxiliaries and other cytosorbs and all. So different trials in a different subgroup has shown some benefits, but at this point of time, there is no conclusive evidence of one or the other. What is your take on that use of them along with ECMO filter, which can be a possibility if in the circuits we can use them because we have a pump which can flow through that. So any role of them?
Very much so, Venkat. As we discussed earlier, it's mainly the infection, cytokine storm, as one of the prime factors which are triggering this event. So, uh, trying to get rid of them to the extent possible within our limits, as Bridge was saying earlier, would add to the treatment aspect. As there was one question I saw earlier, one of the um,
Yes.
audience mentioned about early use of therapies such as usage of CRRT, etc. That would be useful as well in minimizing it. Everything is like a balancing act. ECMO itself is not an answer here, it is a supportive mechanism, as we all know. Besides that, trying to do the source control, right antibiotics, not over treating, not under treating, but it is a for the optimal duration of time the right antibiotics simultaneously, and trying to get rid of these cytokines or the inflammatory mediators through mechanisms such as cytosorb, etc., or heme absorption techniques, that would be helpful as well in bringing the process under control also. So it is a multi-pronged approach, um, supporting the patient with ECMO on one side and trying to balance out by minimizing the effect of these inflammatory mediators on the system. That would be useful in reaching our goal.
So, Dr. Brijesh, there was another question related to you mentioned about even though we don't have a right tool to measure the microcirculation, indirect methods of lactate of your cellular metabolism, or as you said, mixed venous oxygen saturation or a central venous oxygen, indirect mechanism. But does organ dysfunctions or a multi-organ failure um, makes us relative contraindicated to go for this kind of VA-ECMO support in a septic patient? That's a question which raised the point of no return. The protoplasm is lost. How do we actually take that call?
Yeah, and that part for every center's ECMO journey, that's a learning kind of process, if that makes sense. I think so. Multi-organ failure is not a contraindication in my view. Okay, I think ECMO and extracorporeal life supports evolved into particularly high volume centers to support patients like this. I think reframing it's a decision. Let's take a step further. If you've got someone in absolute multi-organ failure and they're in huge shock, but they're not ventilated, right? You're going to make a decision at that time, right? I need to ventilate them, and they're probably going to get worse as soon as I ventilate them. The decision making is not that much different in ECMO. You're still instituting something that can make inflammatory burden worse. So I think, going back to what Dr. Pabani said about inflammation, be mindful that putting a patient on ECMO will worsen their inflammation. That is undeniable. But I'm surprised always by survivors who, with liver dysfunction requiring glucose, for instance. I think the biggest worry I have when you're talking about multi-organ dysfunction is DIC. I think that component, particularly with the addition of a artificial blood surface interface and the inflammation that happens there, is really worrying for me. That's not to say if I had a 21-year-old who was just started his the PT going to 1.6 and we think they're heading into that I wouldn't give them a go, but I would go in there eyes wide open, knowing that I may need to not give heparin. I may need to assess the coagulopathy much quicker. I may need to have a spare circuit ready in case it goes until and if I need to do a quick exchange. Obviously, there are some patients that are beyond. If they're mottled, their lactate's unrecordable, you go see them and they're moribund. I think then ECMO is very difficult to initiate anyway, because they're on such high pressure support that actually instituting peripheral ECMO in a artery that's 2 millimeters in diameter is just a non-starter. So I think what I'd say is I'd always go review the patient, particularly, in-house it would be easy, but if you're providing a referral and retrieval service, I would always go review the patient and then make a call. But in that way, at least you can talk to the team that's referring to you, but also at the same time talk to the family so they know why you're not doing it. But also then, I think good critical care is very much dependent on center by center process. Okay, so if you're a small ICU with not much multi-specialty support, then you may struggle looking after the complexity of sick patients like this. Whereas if you're in multi-specialty hospitals with, a high volume of complexity going through, with the ability of nursing staff and etc. to manage PA caths and all of the above, then actually it may be that you're able to manage the patient and not need to put them on ECMO. So I think that's the highlight. So I don't think there's any absolute contraindication, but I think it's like with any other decision making in medicine and in critical care, is you have to kind of initiate that decision. There's also been some patients where we've said, look, I think ECMO would kill that patient if I put them on now, carry on with full conservative management before ECMO. If then in 24 hours their inflammation turns the corner and they've got isolated lung or heart failure, for instance, then maybe we would initiate some ECMO then. So there's also been cases like that where we've continued to review the patient, the inflammation's turned, they've given IVIG, they've put them on the filter, and actually the risk of DIC worsening on ECMO is reduced. So it's a balanced decision making and quite nuanced in that way.
So it basically individualizes each patient's phenotype and characteristic, and then
absolutely. And trajectory.
Yeah, trajectory. If somebody is making a progress and going into isolated one of those organs, so probably that's an easy task. But you gave a hint towards multi-organ failures into a very sick affairs of DIC can be a more challenging than you have a little amount of rise in creatinine or LFT derangement, which most of the times, the moment we see them oxygenated well, perfused well, reverse back. Most of our cases when they have an AKI, including Kala's case, where we see a quick reversal of those AKIs when they get better oxygenation, including patients who has a VA-ECMO in a hypoxemic situations where hypoxia causing AKI, we believe that. Sunil sir, there was a questions related to when we actually do these extracorporeal therapies, not just ECMO or a filtration or a CRRT, do we need an extra draining cannula which may be useful in them? There are questions related to that.
Sometimes it is not usually, but sometimes when there is a high flow required, in those cases a hybrid modality of ECMO would be useful in certain cases. Dealing with left ventricular function or high flow VA-ECMO in a hyperdynamic heart can lead to severe LV distension and pulmonary edema, then we need to drain that as well. So in some cases, there may be a need for additional cannula.
In most of the cases in standard format, the CRRT and heme adsorption or any kind of filtration is done through the same circuit. Is that the same practice, Dr. Bridges, there? You don't need a separate draining cannula for that, or Dr. Bridges?
Yeah, no, so we filter on the circuit, and we have the Vantive kind of filtration machines.
And,
I think the Fresenius is somewhat different, but we're working with them to improve that.
and as Dr. Pavani sir said, when we have a LV unloading issues, they are again a different set of problem. Both of you, there is another interesting component. Vessels are squeezed to its maximum extent. Very difficult sometimes to even cannulate. One of those examples which Dr. Kaladar presented. What is the role if I have a surgeon on board and I have a graft forming? Can I actually put a maybe not central, sometimes semi-central to auxiliary ones with a cut down returning cannula into the arterial system, or a properly probably chest cut down or a open chest and probably put a central ECMO versus a peripheral ECMO? What is the take, Dr. Bijas, on that?
Yeah, it's a good question. So our practice, we don't go down the central ECMO route simply because the risk is huge. And I work in a cardiac center, so we've never really gone down that. I think the challenge of grafting a peripheral ECMO is the same as a cannulation. If you have a 10 mil graft, the surgeons can't put a 10 mil graft onto a 2 mil artery. It's really difficult. So I think again it goes back to what your centers are used to. You know, if you've got a post-cardiotomy ECMO with vasoplegia, fine, they can come out on central VA. But even now, more and more, I know there's studies ongoing comparing central versus peripheral ECMO in post-cardiotomy. So, but I think in the case of septic shock and vasoplegia, I think we're heading towards predominantly focusing, keeping it simple, making sure that it's peripheral ECMO if we need it. I think there are challenges with more central ECMO, but that's my center's experience. But I know there have been reports and other centers going down the central ECMO route in cases that were not cannulatable peripherally. So I'll be interested what people's experiences are.
Sunil sir, any
That's
point
a
from your
right
side?
comment as well, Venkat, as Bridge said. Especially in our country, in cases like dengue shock syndrome, etc., do we need to consider which type of ECMO at that time? Do you straight away, when they manifest with the dengue shock syndrome, after using the inotropic support, still that vasoplegia is persisting, do you electively go for central cannulation, or do you try VA-ECMO and still not winning on that and then go for central cannulation? That would be
So,
interesting to know.
we in Yashoda Hospital had a couple of cases a few years back when a patient with a dengue with both vasoplegia and some amount of myocarditis. So we went with, and there was a coagulopathy, as rightly mentioned. You name it a dengue-induced coagulopathy, or there is a component of DIC component where you have low platelets, coagulopathy, LFT deranged, everything. Uh, in that particular case, he was happens to be an orthopedic doctor or something. He's from the medical fraternity, and we initiated a peripheral VA ECMO, and the patient supported for a week time, and the patient slowly improved. And that was a case which gave us example key. At that time, the concept of septic cardiomyopathy is an indication in vasoplegic shock was not understood. It's a decade backstory. But in another center, in a recent times in the same city of Hyderabad, when one of our very popular ophthalmologists get into a very bad salmonella typhi septic shock, and team tried to actually cannulate a peripheral ECMO, had no way they could actually pump the blood and improve the circulation. So they went down and initiated a central VA ECMO in the lady who was a very popular retinal specialist, but we could not save her after, in spite of all that exercise. So we have a varied experience. We really don't know, but Sunil sir, you are talking about the grafts to the axillary or a subclavian artery. So will that help? Will that help? Because is that going to help better than a peripheral one? Cut down and put a graft to the radial.
From the literature, I don't have a practical experience of this, Venkat, but from the literature, it was said to be in between going for a central ECMO versus continuing on the peripheral ECMO, and studies have shown it will be helpful. It was shown to be helpful as well in those cases with the axillary artery
So it is
graft.
again institutional practice, your
Yeah.
surgeons, your Dr. Bridges, there is an interesting component. I have money, I have no limit. If I have a cardiac component, can I use a impeller instead of a VA-ECMO to just improve my cardiac output? And anyway, you are using a vasopressors to squeeze your vessels. So what is your take on that?
Yeah, I think there's various types of impellers. I think you'd have to go for the 5.5 and get cardiac surgical cut down to get the most output in this setting versus the CP. I think again, if you've got isolated LV dysfunction, which is not always the case in
Vasoplegic septic shock, yes.
vasoplegic septic shock, then fine. But then you really need bivent support, and VA-ECMO or biventricular kind of coaxial support is the only way. But that has limitations. You're there. As with all of these devices, it's balancing complications. I think putting a low flow impeller is not a plan.
5.5 impeller is available with you. We don't have right now in India. We have 4, I believe. 5.5 impeller is available with you.
Only to the surgeons. So
No.
the surgical team would kind of do that, but we don't really do that in septic shock. That requires an axillary Y graft. You're then putting it in, and it's a very different beast. And then how do you manage the right heart? So I think.
In India, we have another limitation. It costs almost 10 times of your VA-ECMO.
Yeah.
So
Yeah,
VA-ECMO,
exactly.
VA-ECMO itself is a challenge for us to initiate, and in a septic patient where you have so much of complexity, and
Yeah.
I think 10 times of that cost is probably out of box. But as you rightly pointed out, these patients will never have isolated cardiogenic shock. Those cardiogenic shocks will be even in dengue, even in any form of other myocarditis, you will see some component of it. The last component, Bridges, I was very fascinated to actually listen to your lectures saying ki you fix the metabolic component, you fix the hypoxemia, you fix the delivery of oxygen, uh, your heart improves. So many of us, including Sunil Povani sir, in many of his talks about if I have a moderate to mild dose of vasopressors in a patient with hypoxemic predominant respiratory failure, and oxygen is not reaching to the cell, fix it with a VV-ECMO, your vasopressor requirement comes down. If you, even it is there for a day or two, doesn't matter. So how do you actually cut off your VV-ECMO versus VA-ECMO in predominantly a source is respiratory, and at what probably requirement of these vasopressors or myocardial involvement you switch from VV to VA?
Yeah. So I think that's a really good question. And again, it depends on how the patient's presented to you, right? So I think, again, a bedside assessment, where there are some cases that we go assess the patient, they're on some pressor support, but actually we think that pressor support is often due to high ventilatory pressures to maintain their oxygenation. In those sorts of cases, we have just gone down the VV support, put them on lung rest ventilation so their intrathoracic pressures improve, the juxtacardiac pressures improve, and so actually then we're in a much more stable position to then just manage them conservatively with VV-ECMO. I think there are also those patients where you put a probe on the heart and the heart is doing that, and then you're in a vicious cycle, and that vicious cycle you need to just stop with by putting them on VA-ECMO. There's the in-between cases where we have initiated VV-ECMO, their cardiac dysfunction gets worse through repeated ECMO, and then we go on to a VAV kind of or a hybrid solution. And then we keep both venous pipes or the return venous pipe in, simply because the heart often gets better before the lungs do.
So
And
you pull
so
out the arterial cannula.
we take the arterial cannula out and go back to
Go to
VV.
VV.
Yeah. So there's I think it's what the best ECMO element is having the agility to be able to move across the space of VV to VA, VAV, and be able to do that. And I think that's really important.
Sunil sir, there are questions related to your LV venting. Does all these patients where you initiate a VA-ECMO needs a LV venting, and what kind of LV venting do you do in these scenarios?
Venkat, if it is central ECMO, it would be easy. At the time of institution itself, you can set up LV venting. But afterwards, if it becomes an issue, like secondary to your patient developing pulmonary edema, you see LV getting bigger and bigger, etc. Practically, depending on the age of the patient, in neonates and children, assessing through the atrial septum would be ideal. But as the atrial septum matures, in adults it would be a different difficult issue. So either going through the LV apex or through superior pulmonary vein, these are the other strategies which have been described. But obviously, as they are coming out with the other technologies such as Impella, etc. now, if cost is not an issue, that would be certainly ideal. In addition to that, a majority of the adult patients, IABP, etc., would be there from the beginning itself to minimize the issues.
So
But
different supporting devices. What is your practice, Dr. Bridges, in this kind of patients?
Yeah, so I think it's really important to unload. I think we use if the patient is self-unloading, that's the ideal, because I think part of this is that they're able to
You
unload
don't do it.
themselves in this.
So you don't do it prophylactically. You wait to see whether patient is
We assess it.
self-unloading.
Exactly, and we'll sometimes measure an LVDP just to look at the pressure there as well in the cath lab. I think again, part of it's a feel. Is if those patients that we know that are minimal ejection, the LV on echo looks quite dilated, we'll put an impeller in, and particularly if there's clouding and within the echo and there's turbulent and lack of and I suppose stasis within the LV. So I think that's the key. That's an easy decision. Roberto Lusso and I had a debate on Urelso a few years ago versus impeller versus balloon pump, for instance. And I think you have to weigh up the risks. These patients are hugely shocked. Their peripheral limbs are susceptible to ischemia. So it's that balance of actually making sure that we're able to unload the LV. I think more and more, though, now there's more convincing evidence that unloading the LV improves myocardial recovery. So actually, I think we'll have some data coming out of Benedict Strag and others to suggest that the earlier you unload, the better. So I think that's probably the component to have. But there's more and more experience on lava ECMO. There's so much kind of more experience ongoing in terms of just unloading in different ways.
Yeah, I think so. Sunil Bhavani sir, how early? Because if we are using it as a salvage therapy, you will have 100% mortality. It's too late when you actually you crossed the limit or you missed the bus. And in early, the question comes how early, because many of our patients may improve without even ECMO on those early components. And ECMO doesn't come like a steroid 50 milligrams squared. You make it very easy, but ECMO comes with its own set of labor intense, maybe complex intense procedures. So how we balance between early versus a very late salvage therapy?
very good question, Venkat. I had some discussions regarding this with Bob Bartlett as well. Ideally, those certain criteria have been established before this period of time. It would be ideal to go for ECMO. The sooner, the better. But if this is like a personalized medicine, that's what I look at. Each patient is different, so we see how fast the patient is deteriorating. That is a very important criteria. Certainly, before the onset of multi-organ dysfunction syndrome or any of the other organs reaching the stage of failure, and if you want to have a yard or statistic for this, people have described within 24 hours or 30 hours or so, that would be ideal. The trend of lactate will be telling us as well if the lactate is deteriorating fast, in addition to the other factors considered together uh, for establishing ECMO sooner than later.
Okay.
The longer it takes, then the outcomes would be difficult, morbidity will be high, and prolonged duration of ECMOs, and ultimately multiple complications or multi-organ failures, etc., can set in. So sooner the better. It is about the individual assessment of the patient that is very important, as each patient can have a different timeline for deterioration. So watching them, and ideally within 30 hours, 36 hours, like that, that will be the duration of time you can prolong. But for early salvage therapy, these are the ideal indicators, watching different things together.
So basically, you mentioned about the trajectory after your conventional standard therapies, and if the trajectory is going downhill and you have lost all your standard battles, then probably to initiate it early. And if you're looking at a cardiogenic component as maybe Sky C to D or B to C is the points where we talk about all that. The last but interesting component is are we prolonging the death in a septic shock patient by putting them in a refractory vasoplegic shock? Because you put on a VA-ECMO, they will not die, but you are prolonging their death. Is that a ethical dilemma or a concern?
This is also the age group is different as well. If you look at it from the, if you are talking about the vasoplegic shock in those cases, how the outcome is going to be. Studies have shown that in adults, the outcome is much poorer compared to children with that.
Children in pediatric.
So for us, for the decision making purpose, as it is quoted around 65 to 85% of the patients, adult patients, were lost, whereas nearly 50 to 60% of the pediatric patients were saved with that. So that gives us some sort of idea how things are, um, just as for a prognostication sake. The best candidates are probably um, those with the
Younger
severe
age.
septic induced myocardial dysfunction or the septic cardiomyopathy cases, especially when the ejection fraction is going to be less than 20%, as Bridge mentioned earlier on. Prolonging the dying means if it is a futile effort when it is
I'm
started
too
too
much
late
of it.
after prolonged cardiac arrest, or patients with irreversible multi-organ failure, those are the conditions we can think of that this is likely to be a futile effort. Or sometimes we see the major intracerebral bleeds coming up as well, and those could be other situations when it is becoming prolonged futile effort at that stage. So obviously one has to consider the patient's patient journey and then make a decision at this time. The concluding points for this are the irreversible organ failure, severe neurological damage, uncontrolled bleeding. So these are some of the indicators which tell that it is likely to be futile with that.
Dr. Bridges, you must also be coming across such situations. You initiated a VA-ECMO, initially talking about undifferentiated shock, some amount of cardiac, some amount, but it not always not the green and rosy. You go down in the other side. Your myocardium doesn't improve, your vasoplasia worsens, you get stuck, and your patient on a VA-ECMO surviving for a week or 10 days, waiting patients outside questioning you. What is your call on those things?
I think it's a very difficult call to predict outcomes, and so I think it's having clarity of decision as to what you're getting into is really important. And I think putting a patient on, stabilizing them is key. I think at the point of initiation, we know that if you're in hypoxemic respiratory failure and you have a cardiac arrest, ECPR in severe hypoxemic shock is a poor outcome. And so I think ECPR in that setting is really difficult and probably should be questioned. And I think that's where maybe the prolonging death element is there. However, if you pick out your patients, actually these patients are with inflammatory, non-ischemic myocarditis have some of the best outcomes. You know, they're often young, they're often minimal comorbidity. You've got a reversible inflammatory process that you can dampen through antibiotics and you source control. Actually, you've got a cause for the injury. And so we would hope that those patients would reverse very quickly. And as Dr. Pavani said, the age group is really key. As with anything in critical illness, you know, if you're older, unfortunately, your outcomes are worse. So I think it's just having that pragmatic kind of approach to it, and being open with the team that you're initiating with and decision making, but also with the family to say, look, we've put the patient on ECMO. I don't know where things are going to go. There are cases that we have that don't recover, but we have an exit for transplant and durable support. So that could be an option if we find that actually this is maybe an underlying DCM that we just weren't sure about, and actually this is sepsis, etc. So that could be an option.
Dr. Brijesh, those are for isolated myocardial issues, isolated lung issues, where we bridge for transplant, not bridge for recovery. My question is, in sepsis, when you actually land up into vasoplegia, organ dysfunction, these category of patients probably not will be bridged for any transplant, but if futility of care one side and the duration gets prolonged, the death gets prolonged, you know, patient is not making a progress, there is no question of bridging for a transplant. These are all different subset of population. I'm talking about organ failures with sepsis and organ failures. How do you handle those situations? You just take a call and discontinue, or what do you do?
So in terms of end of life care, because that's what we're talking about, right? Those decisions are made in an MDT fashion. So we have an MDT, multiple critical care consultants, nursing staff, any of the host teams like
What are the
cardiology,
points?
etc.
What are the points at which you take those MDT, end of life care? What
Yeah.
makes you to take, okay, look, we are done now, patient is not improving? What are the cutoffs or the points which you make you to take those decisions?
I think realistically, it's more about actually you can't continue to support them. So despite ECMO support, they're still deteriorating. So the lactate gets worse, their gut goes off, they have a neurological issue. So I think those are the elements that probably determine it. You know, status quo is not a worry for us. We'll maintain them as they are, and it may be 2 or 3 weeks before their shock kind of improves, and then we see a recovery. In our experience, generally it happens 7 to 10 days. You see some inkling of improvement, but again, this is not an absolute. There's a normal distribution towards this, and so I think the more we look at it, we probably stretch them out longer with the hope that there's recovery, especially if you've treated the underlying cause.
Yeah, I think we had a hour-long discussion. Fantastic. A lot of insightful discussions by both of you, Dr. Sunil Povani sir and Dr. Brijesh. I thank both of you for your time, your probably a wide horizon of knowledge sharing. I also thank all the audience there participating very actively. I have more than a half a dozen of questions yet. Probably we will answer them all. Dr. Kaladar, thank you very much in bringing the case and discussion so that we could actually take us through. And I thank all of you and conclude this session. Thank you very much.
Thank you, sir. Thank you very much. Thank you, sir.
Thank you, Brijesh.
Thank you very much. Thank you.